So once again, we say welcome to Lagos Talks 91.3 FM. Like we do every week, we bring you this program that we call Lagos Weekly. It's an update on what is happening in Lagos. Beyond the criticism, beyond the quizzing, the querying, the distrust, beyond the question we ask government, like we say every single time, it is not all bad, it is not all rosy. So we want to know today what really is happening within the health sector in Lagos. Looking at the population of Lagos, looking at the number of health facilities we have in Lagos, looking at the prevalent ailments that we have in Lagos. What is the government doing in particular? Since, especially COVID, that the Lagos state government said they're ramping up the entire health provision. We hear in some quarters that Lagos has one of the best health um, care, should I say, structure in Nigeria. Some say it rivals Abuja, some say it is better than Abuja. But we want to hear from them what they say so that you can go out there, confirm it, and get back to us. My name is Oluwakayode, and today we're at the Ministry of Health right here in Lagos. And my guest is the special advisor to the governor of Lagos State on health. And that is, should I say, Honorable Dr. Kemi Ogunyemi. Good day to you.
Good day. Thank you for having me.
And thank you for being a part of the show. Let's start from there. There's this talk about Lagos having one of the most structured health service in Nigeria, and many have said that that cannot be possible because in Lagos we have a lot of demands. We see that we lack a lot of things. But tell us the real picture. In Nigeria, where does Lagos stand?
Oh, thank you so much for that question. And I'm so glad you're having this program where it gives us an opportunity to actually basically sell ourselves, market ourselves. And you're right, we hear negative things, but we're doing so much. But first, let me just start off with what the agenda is for Lagos State. Right from when this current governor started, we call it the Themes Plus Agenda. The themes, the H in themes, THEME, plus agenda. The H is for health. And basically, the bottom line is our objective is to provide access for everybody, no one left behind, to good, affordable, because we know we have people who cannot pay, quality healthcare. And that's where we started. And in this ministry, obviously, Ministry of Health for the Health, that's what we've been doing, that's what we're striving to do continuously where all challenges come in. Let me also start by saying that there is our system of health, our ecosystem is a complex one. It's complex. So when you have a complex health system, basically means you've got the middle and you've got many parts that feed into the whole. So it's not just one agency that is in charge of the entire health system. So it's complex because there are different aspects of healthcare. So you want to talk about maternal, you want to talk about universal health coverage, you want to talk about hospitals, you want to talk about pharmacy, you want to talk about, there's so many things that come into health. But Lagos State, absolutely, it is not called the Center of Excellence for nothing. We have a whole line of people who come into Lagos, they want to work within Lagos. And so yes, in answer to your very first question is, absolutely, I believe, not because I'm a Lagosian and I'm the special advisor, I believe Lagos just trumps all. We're number one, people follow us, we want to set an example. There's some things that maybe another state is doing, we look into it. For example, our accreditation agency, we've got other states saying we're the only ones that have HEFAMA, which is the monitoring accreditation agency. We are the only state that has it. And now other states realize that, oh, wow, we need to do this. And so they're coming to us and we welcome them with open arms. Come and learn from us, learn from our errors, our challenges, so that you can actually perfect it. And that's who we are. We are a small state, smallest state, that has 11% of the population of Nigeria are here. We are densely populated. All our services are strained because people come from everywhere. We don't have a border to stop people from coming in. So it's not just Southwest, it's not just Lagosians, it's everybody basically in Nigeria who wants to come to Lagos, come.
All right, and it's good you speak about that, and it's open access to everybody. But when you look at Lagos, would you say that open access has should we say, made providing healthcare difficult for us, or is it easy to manage considering the scope where Lagos is?
So I won't
Nigeria.
say it is difficult. I'll say it is challenging because it comes with all its issues, from cultural to non-compliance to different things that will make it difficult for us to provide what we want to provide for everybody, regardless of where you've come from. So you come into a hospital, we don't ask what state you're from. We don't ask what your ethnicity is. You're in Lagos. The only thing we ask is register. So that's why we have LASRA. Bring your registration card. Let us know that you are actually living, you're an indigene, you reside in Lagos and all that. So absolutely it is challenging. Absolutely. Or some people don't have addresses, especially when we have outbreaks. It's like, where do you live? They give us wrong addresses. We can't verify anything, but we have to look after them. We don't say, no, you didn't give us the right address. We don't know until we want to follow up. And we do follow up. And we find out that it's the wrong address. People abscond, or people don't pay, they don't have any money. And we're telling them, come and get it. I know there's so many things we do within health. Come and get health insurance. And we don't find them again. So those, I wouldn't say it is difficult. I'm just going to say it is challenging. And we can't help everyone. And don't forget, everything we do that is free to our citizens, our residents, is actually not free to us. It's free for them. But somebody is paying for whatever it is. Whether there's a road traffic accident, whether we're picking up people on the streets, we don't know where they've come from, whether they've been victims of armed robbery or anything. We treat everybody equally when it comes to public care, health care.
Okay. All right. And you spoke about the patients you attend to. And we look at it now. When you look at Lagos, how robust is data on health patients we attend to? Approximately how many patients do you attend to in a year?
Oh, wow. Good question.
Do you have that data?
I do have that data. I will not say it on the top of my head. I'll just say the increase. We have a 50% increase in the number of people that we see per year. It goes up. It's never come down. It's never come down, from pregnant women to even the elderly, to children, to school children. So we're building more hospitals, we're building more schools and all that. But so yes, it increases the number of people, especially in primary healthcare. That was what I was looking for earlier. In primary healthcare, for example, if you know, the governor realized that, look, we can't have just one section of primary healthcare and just have it blank like that. He divided it into 6 districts, and there's a PS in each district. Now, each district, we just did our report.
And the PS,
data.
the permanent secretary.
The permanent secretary,
for Nigeria.
Okay, the permanent secretaries, they're in charge of those districts, and then they have directors working under them. And the whole idea, and District 1, 2, 3, 4, 5, 6, the whole idea is that we realize that in some areas of Lagos, maybe there are more women, or maybe more children. So we collect that data. You're talking about data.
Yeah.
Data has been a problem. It's a problem in Nigeria as a whole. And we find it as a challenging issue for us in Lagos, especially now that the technology relies on a lot of data. Our decisions that we make, from myself and the commissioner to tell Mr. Governor, relies on data. You can't go to Mr. Governor and say, I want this for this. You need to say why. You need to provide the data. And then even when you get the funds to do something, you now have to come back and show that this is the percentage. So we've had an over 50% increase in the number of patients. And when I say patients, I'm dividing them into pregnant women, women who breastfeed, family planning, children in school. Immunization went off the roof, over 100%. Immunization of kids.
Okay. What your findings, is it that there was an increase in number of children that are given birth to, or is it an influx from outside Lagos, or is it generally just an increase in the interest due to sensitization?
Yeah, right. And so there are many things that make for an increase. So first of all, awareness, which is from us. So you create this awareness, you tell your citizens that do this, do that, then the more people who come. Well, at least some people are still dead set in a ways. Community engagement, a lot of community engagement. But you see, the more you say things like you're a victim of your own success. The more we get this and the stories go out there, even though maybe sometimes the media doesn't pick it up from the community, the more people are coming in. Everybody wants to be in a place where things work. Even though as much as we're not perfect, we do have challenges. We collaborate with private sector, by the way. We collaborate with different people, our international partners, in order for people hear these things. The federal, talking about international partners, they know Lagos is so mixed. They can get a lot of data from what's going on. And like I said, that data helps us make decisions. So if you want to make decisions, for example, Mr. Governor made a decision on pregnant women antenatal care because we gave him the data on maternal and child mortality rate.
Right.
So he looks at the data, we tell him this is what we want to do. He looks at it and then we look at the economy, because health doesn't work in a vacuum, by the way. So you've got the environment, you've got the economy, you've got education, because we go into schools as well. So he makes a decision that, okay, you know what? Antenatal care, let's just make it free so people can come. And, unless we're talking about maternal death now, I don't want to go into the issues because I'll just be jumping off points. But that's the whole idea. So when people hear that Lagos is where they have this specialty, Lagos is where that's why people are coming. Lagos is where you can make money. Lagos is expensive. So come and sell your wares. So we're getting people. The Institute of Migration said that 3,000 people come into Nigeria, into Lagos. 3,000 a day.
3,000
That doesn't
people.
include those. We don't have statistics on those who are leaving.
Yeah, okay.
So
Fair
can
enough.
you imagine the sheer number? That is 3,000 a day. Even it was like mind-boggling. Like, how can 3,000 people come in
Into one state.
into one city? That's from Institute of Migration. That's not from us. And they give us their data.
The
Because they measure,
IOM.
and that's the ones, IOM, and they're the ones that measure this thing. They're the ones that know where they get. I'm not going to analyze the data, but that's what they said. So all these people are coming in. So you cater for these people, young people coming into school, the same people bringing in their family members. They're coming into Lagos, come to Lagos, and then the people coming back. I know you talk a lot about people jackpying and going, but people are coming back. They may be in small numbers, but the point is that they're still coming back.
Okay. And I think we just also put you in trouble because during that health month, one of the sessions where we spoke about, was it childbirth or delivery? And some of our callers, which was shocking to me, a lady called and said she never knew antenatal care was, all this immunization and stuff was free at government hospital. That she had actually stopped taking immunization for her kids after like 6 months, or was it 3 months? Because she was taken at the private hospital and she was paying and it was too expensive for her. So on that day, I'm very sure a lot of people got to know that it was free and we're adding to your numbers.
And it did.
But, but in addition to that, since we're talking free, what quantity of the service, or maybe that might be too much, but what are the services that you offer as Ministry of Health that are free to Lagosians? Because to an average Nigerian, Lagosian, government is always taking from us, which is a reality. Increase tax, increase this, but you spoke about free. What is free in health from Lagos?
Before I say that, you talked about increased tax. I wish I had the exact figure, but do you know that less than half people in Lagos pay their taxes?
Less than how?
Less than half, probably about, I don't know, maybe 40, 30%. It's gone off my head. It is mind-boggling. They are not paying taxes. You may be paying your tax. Your neighbor may not be paying your tax. And we're not, we send, revenue people will tell you, everybody talks about Lagos, IGR, they have a lot of money. They are not paying taxes. If people were paying their taxes, trust me, there'll be more things that were free. But talking about free. So when it comes to health, so immunization is free. All those vaccines, they're all free. Nobody pays for it. So if people are listening to me right now, if you go to a primary healthcare setting and they ask you for money for immunization or for a vaccine, don't do it. It is free.
It's free.
It is free.
Totally free.
You go
You're
in,
not paying for
you
a pen or
want
anything.
your child to be immunized because there's a reason why we want that. One, we don't make the vaccines. We pay for certain things. We pay for the syringes, for the needles, for the manpower, for all of that. But for you coming in and bringing your child, it is free. Why is it free? Because we do not want your child to have those diseases. For example, diphtheria. We had an outbreak not too long ago. And we gave over 2,000 vaccines because of that alone. Nobody paid a dime, and we kept on saying it. It is free. It is free. It is free. So nobody should come up and tell you that they were paying for vaccines. When it comes to antenatal care, for a good 6 months, in fact, Mr. Governor hasn't even said, okay, I'm not paying any more for antenatal and all that. Antenatal care was free. Is still basically free, to tell you the truth, including delivery normally and by cesarean section.
Okay.
That's huge. Okay. Because for somebody to have surgery, you know everything that goes with that.
Okay.
Free, totally free. And despite that, and one of the reasons he kept on extending how long, he said, obviously it can never be free forever. We have to pay for these services. So he started with 6 months, then he went to another 3 months, and then he went to another 3 months. Because we realized people were still not taking it up. They were still going to the TBAs. They were still going there.
Traditional birth attendants.
Traditional birth attendants, sorry.
Yeah.
And people are still dying because they go there and all that. And it's not, and then in line with that, we also have ECOSHA. ECOSHA is the health insurance for the people who are vulnerable, who cannot afford it. And despite that, saying that, look, if you get health insurance, your antenatal will be free, your child will be free, because the free stops after you have the baby. So should your child need special care, should you yourself get an infection and you need special care, you have to pay for that. Health can be free, so children, their care, their eye check, their vision care, we go to the schools, even from the primary, it's free. So quite a few, if you're elderly, you do not have any income, you get free insurance. That means you go, if you have malaria, you don't pay a dime. So there are quite a few things that are free. Last year we did a free medical outreach in all the 6 districts. We saw over 24,000 Nigerians. They got free eye glasses, they got free checks, blood pressure, everything, and then they got free drugs for 1 whole month. I mean, no other state has ever done that, where the government itself is just giving it all out.
So let's look at an illness that is very rampant in Lagos, and that is malaria. If an average Lagosian, has malaria right now, is that a free service for that? Okay,
so have you heard about the malaria elimination, pre-elimination malaria that we just launched? You probably haven't heard about that.
Tell us about it.
It was all over the news. So statistics have shown us that we actually have less than 3% of the population having malaria.
Less than 3%?
Yes. You said it's so rampant.
But that's why you see everybody go to hospitals.
They say they have
what
malaria.
You see. Yes.
But guess what? So what we launched last was that you should get tested first to find out whether you have malaria or not. The symptoms of malaria are almost the same as COVID and some other diseases.
They're not peculiar to malaria.
They're not peculiar to malaria. So you test. There's a new test. And by the way, that is free as well.
Okay.
You test for the malaria. If you have malaria, you get the drugs. If you don't have malaria, your physician will let you know maybe there's something else they need to check out for. What our people do, it's a culture and we're creating that awareness. 3 days ago was World Malaria
Friday,
Day.
Yes.
So we're trying, and so if they go to the pharmacists also have been trained, have been given the kits to test. Because some people, you go and just say, my body aches, I have a headache, I have this, I have malaria. And then they go, some of them even know the names of the drugs, they go and buy it over the counter. We're saying no to that. Go to your primary healthcare setting. Free test for malaria. Not
free
everybody.
Tests.
Free FREE, free. You're not paying anything for it. And that is when you're not feeling well and you believe you have malaria. But before that, we're saying this is how to prevent malaria. Prevention is always better than cure. Always. You don't lose. When you have malaria, loss of manpower, loss of economy,
Yeah.
loss to the economy, loss to the state, loss to your company that you work for. We need to test you. But how do we prevent it? So we're encouraging people to use mosquito nets. We're encouraging people to check the environment, stagnant water, or clean your environment. Don't throw things into the gutters where there's no free drainage. Because where there's stagnant water, they breed.
Breeds, yeah.
Well, and then you get malaria. And then it bites you, and then it bites everybody in the house is bitten, and everybody has malaria at the same time. That's in a
So
mosquito.
for clarity, you're saying for a fact today that approximately 3% of Nigerians.
And we want it down to 1%. So
So approximately 3% have malaria. So it's not
the incidence of malaria.
Okay, the incidence of
Yes.
malaria. So in terms of all the sicknesses that come, incidence of malaria just accounts for 3%
Absolutely.
of all sicknesses
Absolutely.
in Lagos.
Absolutely.
So a lot of the people that claim, I can say claim, they have malaria now. It's nothing but.
Absolutely. Seriously.
Wow.
It's a fact. This is a fact. And World Health Organization have divided it into, the areas, the countries are really, I think it's red, green, blue in colors. We're right here. We're not here.
Wow.
That's why it's easy for us to say, oh, it's only less than 3% is like low incidence. And we're under, I'm telling you, we're low.
So is it, I want to go into policies right now, but this malaria thing is really interesting, considering the Health Month thing that we've just done. So is it possible that, because you talk about stagnant water, we see that almost everywhere. We see mosquitoes flying everywhere, oozing in your ears every night. And after a while, you realize you have fever and you assume it's malaria. Is it possible that it's because we've built antibodies and resistance rather, and even with all the exposure to is it Anopheles mosquito?
Anopheles, the female.
Yeah. We are no longer able to get malaria. Is that a possibility? Because I'm still shocked that it's just 3%.
No. It's mainly because, first of all, people are more aware. Nobody wants to get malaria. So they're trying their best. It's not everywhere that in your house, will you say you have, if you leave your door open, and if you leave your window open, the malaria is going to come in. Absolutely. Then you close it and then you sleep and then it just bites you on your skin. And if you're lucky, maybe it's not carrying the malaria, and then you don't get malaria and you're done. You just see bites on your body. And some people will be bitten and then they have malaria. But because people are more aware. Two, you can't really build, if you're resistant to an anti-malaria drug, it means you can continue having the malaria.
Yes.
It doesn't mean you've got an immunity.
Itself.
The parasite itself will still, when it comes, it still causes havoc.
So, maybe what I meant to say, have we built immunity, not resistance to the drugs?
Yes.
So have we built kind of immunity? Our system is now stronger?
And we have so many. No, you haven't. That's why some people will take anti-malaria and they'll feel good, they'll feel better. When you test for malaria, generally when you take blood, they can say trace.
Yes.
1+, 2+. And then there's some people, they say people that have SC, they don't. So there's some people that do not just get malaria. You've had malaria before.
Yeah.
I've had malaria before. I took anti-malarials and then it's 1 day, 2 day courses. Now it's no longer the 7 day and whatever. Some people take the Sunday or whatever to prevent malaria. Some people ensure that they spray. And all that. So there are many ways of preventing malaria. When people have it, they say, malaria, I'm not going to have it again and all that. Whatever the case is, the point is that actually in Lagos, it's less than 3%.
All right. So now looking at... Recorded, yes, okay.
So some people don't take anti-malarials, they take agbo, the concoction.
Yeah.
We don't have records of them.
Okay.
So recorded. So that's the thing about data. So you can have a whole segment, like somebody can argue that that's a lie. I can tell you I know a community where blah, 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 but we never got that. These are recorded. So the 3% are people that have come to the hospital, and asked for anti-malarial. They've been diagnosed or have asked.
Okay. So is it, looking at this right now, is it okay to, should I say include, because I believe there are certain drugs that you cannot buy over the counter. Is it necessary to include malaria drugs in drugs that you should not be able to pick over the counter without a doctor's prescription, seeing the likelihood of an abuse?
Yeah, well, would you really call it abuse? it doesn't make anybody feel good when they take anti-malarials.
Yeah.
So
But
I would, when I
assume,
say abuse,
Yeah.
there's just an assumption. So whether you put it or not, there are many drugs, even antibiotics,
Oh, yeah.
that should be listed. People go in and they ask antibiotics.
Yeah.
The point is, so pharmacists are they're key stakeholders in this, because people go, they bypass their doctors and they go straight to the pharmacist. So what the pharmacists have been told, obviously, is that, look, here are the kids. If they come, ask them to go and test. And you yourself that is being tested, look at it, or whatever. Diagnostic centers will have it. Go and test. I do have malaria. This is why. So the pharmacist will say, have you been tested? Yes, I went to a primary healthcare setting. They just didn't have anti-malarials. They said I should come to you. And that's what we're saying to people, that look at your test. You can take a picture of your test and say, look, this was the test that they did for me. I don't need to repeat the test. It's a one-time test. So the pharmacist can send it to you. To take drugs that you do not need to take is not good for you. So I wouldn't necessarily say they abuse anti-malarials, because why would you want to take anti-malaria? It doesn't make you feel high. It doesn't make you feel good. In fact, it causes, so it's not like a drug that makes you feel good, that you want to feel good for the sake of it and then you go and buy it. So I wouldn't call it abuse.
Yeah.
I'm just calling that the rules, which is what you're trying to say, that the policy of the law against just going over the counter and say, I want this. You can't do that in other countries. You can't just go and say, please give me broad spectrum antibiotic. I have a fever. I think I have an infection somewhere. I have stomachache. I think it's food poisoning. I have diarrhea. Please give me, and then the pharmacist, who's not a physician, is diagnosing based on you selling them. So we're trying to eradicate that. Prescriptions will come eventually. We're working on stuff like that pharmacies, people cannot just come to you and say, give me this. They're not doctors.
Okay.
Yeah, so that's what we're trying to
do. So when you look at, one of the things that we've noticed in Lagos in particular, of course, we've seen either the WHO sponsored or Lagos State driven, should we say sensitization or projects where you go, you see either nurses or healthcare practitioners going from door to door, giving immunizations or certain things. And I've seen personally, and got report from many people who would say they come to their area, I won't take it, I don't know what they're giving me. How do you deal with that? And what are you doing to ensure that Nigerians, first of all, trust governments enough? Then they're able to take what they know, what they need, even though, when it's coming from government.
Well, so let's do the immunization. That's the easiest one. So we have far to reach areas where people can't even come to us. And that's the whole point of the Things Plus agenda, the age, that people will have access. So we don't wait necessarily. So there's some areas we know, we don't necessarily say they must come to us. And that's why you see people, community workers, you see all these health educators going to the people. That's how a responsible government should behave.
Since you spoke about Mercy Hospital, I've heard questions, different quarters saying, why concentrate these huge funds on a huge hospital somewhere on Lagos Island, where you have different parts of Lagos that require, even if they have 1/10 or 1/20 of this, it will work for them. What is that plan? Because, that huge one, and we need a lot of hospitals on the mainland.
That huge one you're talking about was small. It's still small. It wasn't enough. That's just the bottom line. You don't just wake up and say, I want to build a big Mercy hospital. No, the current one was not enough. That was
even
it.
For that.
Even for that. It wasn't
purpose.
just for that area. It was just, it's like saying Lasut is just for Ikeja. No, Lasut is for everybody within. That's why I'm saying that we only have one tertiary. Mercy is a specialist. They have them abroad. Even in England, Great Ormond Street, hey, the big children's hospital. It's there in London. They didn't say, oh, go and open it in Yorkshire or that is it. They built on an existing. So we didn't just say, and it's right there in the middle, in the heart of Lagos. It's part of Lagos. It's part of the healthcare. What all we've done is basically refurbished and made it larger so that they can have better capacity for the data we're getting, for the number of people that are coming, that are bringing their children. We do not, children are very important. Children are born, some children are born, unfortunately, with diseases, with conditions or whatever. They can't just go to a primary health care. Yeah, they can't. So you've got a specialist hospital. It's like saying Island Maternity. if they're bossing, maybe we need to extend alignment. And it doesn't mean we do not have other MCCs. We have quite a few of them, but you want to expand that one that makes Lagos Lagos.
Okay. All right. So, and when during COVID, one of the outcomes we got from COVID is that Lagos realized there is need for more secondary hospitals in Lagos, and there were talks then on where to situate. I think there were talks on building, is it about 5, if I get the figures right? There were talks about Okwe, Ekwe, and then I know that some House of Assembly members were fighting to bring it to their area, that you're trying to lobby and all that, which is normal because you need to fight for your people.
Absolutely.
Where are we with that?
Okay, so I mentioned Ojo.
Yes, okay.
Then there's the Femi Gbajabamila Hospital in Surulere.
Right.
Then there's the one Tinumbu Hospital. What are we calling it again? I can't even. Sorry. Well, I meant Tinumbu Hospital. It's secondary. It started off as primary. It's secondary.
Where is that located?
It's Ojo. It's that area. It's not as big as the big one. I mean, Ojo is a big area, and we're not. Yes. So people clamor to have hospitals near them. Fine. If we could have 2 in every single local government, it would be fantastic. But at least you have 1 in every local government. And there's some local governments that are local governments. So, for example, Alimosho also has a huge Rauf Aragbeshola primary healthcare center. It's a 24-hour, and they work hand in hand, even though it's a primary healthcare center. But Alimosho is huge. Alimosho is probably one of the ones that are going to become a tertiary. And while you're doing that tertiary, then you build another hospital. So it's not you're just building a hospital because everybody wants it, but each local government. So during COVID, we had 30, I would say about 28 general hospitals. Now, including all the MCCs, now we have like 34, 35. So hospitals, you can build them. You've got to staff them. So you don't just, because somebody wants, we're now going to build a hospital. You can't. Government doesn't work like that. It's like, okay, what are the needs? What exactly do they need here? And that's why we partner with private hospitals. So even in Lagos, I can mention private hospitals like Evercare and all that. They're also there to meet the needs. So you don't just build hospitals all over. You have to be strategic in it. You have to know what your objective is, who are you targeting, and all that. So that's how that works.
And recently, we know that when we talk of primary health care, a lot of times we situate it with local governments, that local governments have a huge responsibility in that. When local governments are putting up hospitals, how do you, any local government can put up any hospital at any time, just to cater for the people. But how do they work with states to ensure that, or rather, do they work enough with states to ensure that it serves the purpose? There's a local government where there's a hospital, and that is like the major hospital in that area, but it's not a 24-hour hospital. It shuts down at a particular time. In such a case, the people in that area, how will they manage emergencies at night?
So there must be a hospital that is for that local government.
So
maybe it's not near where you're talking about. Because there's only one, in your local government, it's just one local government. One chairman. Yes, you have the LCD and all that, but it's still one. And yes, they are responsible for their primary healthcare settings. We work together. It's a collaboration. We appoint the MOHs. The Primary Healthcare Board is under Ministry of Health. The permanent secretaries that I mentioned in the districts, they're under primary health. So it's a combination, because the grassroots is local government. The idea is that they know what the people want. They go to them. So if some groups want something, they're not going to come to myself or the commissioner. They have their meetings. They actually have their health supervisors that help them, that coordinate certain things. They build the primary healthcare settings, absolutely. But we staff it. So it's that combination. So we inform them, we want to do this, they know that. They call us, they want to do this, they need this.
So they consult you before even building?
Not necessarily. Well, they let us know, absolutely. Especially now that we know that we want certain type of, this is how it really should be built. They're all built in different ways. They gave us, at the end of the day, some of our hospitals are primary healthcare hospitals. When you look at the infrastructure, you wonder, was this. It never started as a hospital. It was a secretariat.
Mm.
So now they build another secretariat. They move to the secretariat. That's the local government.
Okay.
Then they give you this, and we take it on and say, okay, this is going to be a primary healthcare center. So that's why when you go into some, you say, what, it's upstairs here. But we're changing that. So we're trying to have a standardized type of primary healthcare structure and all that. But we work with them. They own the land. The people are their people. They serve the people. They're elected and all that. So it's a collaboration. Absolutely, it's a collaboration.
You said that, you just took the words out of my mouth. I was going to ask if, what a FEMA does and if there's any standard structure for hospitals, because one of the questions was a clinic, a hospital. What is the difference? Because you go to some places, they call it a hospital, and you're like, okay. And you go to some places, they call it a clinic, you're like, okay, you're even bigger and more structured than the hospital. So what really is the difference between a clinic and a hospital to an average Nigerian?
To an average Nigerian, a hospital is bigger. Average Nigerian is a clinic, Monday to Friday. The doctor, nurse is there. They don't admit. It's just that some people call their hospitals clinics. But if you really think about the majority of hospitals are hospitals, and the clinics are just.
But in the structure of Lagos, what is a clinic? What is a hospital? Or is it the same thing?
So they're all. It depends on. So Hefama that regulates. So people, because Hefama is under kind of my care. If I put it that way. So every single day, I get people requesting to set up a clinic, or to set up a hospital, or diagnostic center, or a cosmetology clinic. See, I'm using the word clinic. Nobody says cosmetology hospital. So a clinic, people come into a clinic. It's usually for healthcare. For us, at least it's healthcare. But there's a laser clinic, or they do this. So Hefama will now go around, and there's a criteria, there's a standard. It's like, if you want a clinic, this is what should be in it. So you can have a clinic that is a 3-man clinic, but we look at what are you providing? What service are you providing? Oh, I'm just doing preventive care. I just do this. Okay, this is what you need under there. So by the time you're graduating to a hospital, it's a higher prerequisite before we register you, before you get the logo to say, we have looked at you. This is a hospital. It's a 24-hour hospital. It's a Monday to Friday hospital. There's no hard and fast. So you can't say you want to open a hospital and we say it must be 24 hours. You tell us what exactly it is that you want to. Dental clinic. You know what I mean? It's a dental clinic. It's a clinic. So a clinic is a place where a service is provided, but not necessarily that the patient is admitted or they do. Yes, exactly.
Right. And when you look at the hospitals, how has migration, or let me just call it what we call it, JAPA, affected healthcare in Lagos?
Oh, in a huge way. Oh yeah, it's really, really affected us, manpower, basically. So our staff, our doctors, our nurses, our pharmacists, they're working under a lot of pressure. Because, so I'll just give you an example. You have a 20-bedded ward that you normally man with 4 nurses. You just use nurses, and maybe 3 doctors are there in and out, and they're manning other whatever. So when Japan really, really started, it's like, so the 4 nurses will go down to 2. They're still managing the same number of patients or whatever. So that puts pressure on those 2. Sometimes it can affect quality. Because if I'm standing here looking after 1 patient and I have 10 others, because I should really have only 5, but now I have 10, it affects how quick I go and see the patient. And then the patient say, oh, they're slow. Oh, I was in pain for a long time. So it did affect us a lot. And we really had to sit down and how are we going to manage this? And I used to work at the Health Service Commission there, which is tasked with recruiting and whatever. So we started recruiting. We're recruiting. But we can't compromise on recruitment. Because somebody will say, they didn't give me a job. Well, we have a process. You have a process. You do an exam. Depending on your grade level, you do an exam. We interview you. We check your credentials to make sure that you are really, really qualified. Because we have a lot of quacks. And people forge certificates. So that delays. Sometimes some people complain that, oh, there are many people that want jobs or we do not give them. However, so that happened. But what we've done in Lagos State, Mr. Governor has approved the creation of our own University of Medical and health sciences, where we're going to train more doctors and more, in fact, double more doctors, more nurses, more pharmacists, more healthcare professionals. Because we found that in Lagos State, the number of people that we train is not even meeting the demand of the people. There's not enough supply. So people are leaving. We're not replacing them fast enough. Even though people are coming from they're jackpotting into Lagos from other states. People are not, I'm yet to find somebody who's jackpot from Lagos to another state in Nigeria.
Okay.
They usually go abroad, and then sometimes they use it as a stepping stone for them to go abroad. So we're starting off this year, taking in more people, more students for medicine, for nursing, for pharmacy, and all that to meet the gap.
That's to bridge the gap of, should I say, LASUF? Because all the people that graduate, all the students that come out from your university, because you offer medicine at LASU.
Yes,
right?
LASU.
Yeah, so,
it's not enough. There are not enough spaces.
Yeah, so you're now setting up a specialized.
Yes, we're setting up a university of medical and health sciences.
That's
where we
a specialized university.
Yes, strictly for that. So it's another university. It's another, say, LASU, that part of the medical. It's still in existence, the one that we have now. But because we have students who want to study medicine and there's not enough room, and then they study zoology and all those other, they offer them other things that's not really what they want. So we want to, ensure that they do that. But apart from that, the people who are jackpotting back, the people who are enticing that you need to come back. I mean, I jackpot back, but not when things were really, really bad. I went and I came back. That was just me. But in line with, say, post-COVID, people are coming in, specialists. So we're offering them PPP. There's a whole PPP office in Lagos. Absolutely. One
public-private partnership?
Absolutely. Public-private partnership that Mr. Governor has set up. Somebody is running it, and we look at MOUs, or we're offering. It's like,
and what does that do? Are they setting up hospitals, or they are working with government in your?
If they want to work, it's up to them. If they want to work with government, absolutely, let's see what we can do. What do you want? What do you need? Some people want to set up, so government can say, okay, we're going to give you the land, or we're going to give you the building. However, while you do that, 20% of your people are indigenous, and they're not going to pay high costs. It's going to be free to them. So that's why I say it's a public-private partnership. Government can't do it all. We cannot do it all. So LASU, for example, if you from cardiology to it's all a PPP. Our ICUs are PPP because then the people come in with their equipment. They come with the talent. So we have a lot of people who come in once a month, twice a month. Now they're saying, you know what, it's working. But they're specialists because we have a lot of general hospitals. So they come in and the PPP is there for them in whatever we need.
All right,
so
we need to bring it into right now. But just 2 or 3 more questions. For the average Nigerian or Lagosian who feels dissatisfied with the quality of service that he or she is getting, we've seen reports of people that went to the hospital and they were misdiagnosed. I got my glasses some time ago, and the prescription I was given, I felt there was something wrong. So I went to another place, and the guy told me, what's wrong with him? Does he want to render you blind? That was like a couple of years ago. Now, for Nigerians that have gone through a process in the health sector, be it private or public, and they feel dissatisfied, they feel they were exposed to danger, what can they do?
They let us know.
How?
They can write, and they do, by the way. So don't think we don't get reports. So HEFAMA is there. That's the reports. HEFAMA investigates. If we have to shut down a hospital, we'll shut them down. I mean, I get also requests to reopen. The public are not aware that when we hear of these things and we investigate, we actually shut the place down.
So there are places we've shut down?
Oh, absolutely. They're still shut down. And until they meet the criteria, they're not going to be reopened. So I approve the reopening on advice from HEFAMA that, okay, they've paid the reopening fee. They have shown us their records. They have shown us the certificates of all the people that work there to ensure that, because Nigerians try to do all sorts of things. They give you the exact thing you want at the beginning, then you approve them, they're open, and then somehow something happens and somebody in the public will report, and then we will investigate. We immediately shut down. And there's some that is still shut down up to now. But we will reopen once they meet, and then we review after 3 months or 6 months, depending on what the reason why we shut them down. So when people are disgruntled, or they can write to the Ministry of Health, they can write to the Commissioner, they can write to the PS, they can write. It doesn't matter who they write to; it will get to the appropriate people to investigate, and we welcome it. In fact, because there's so many hospitals in Lagos. Hefama is only it's an agency; it can only do this bit. So we actually rely on you, on people, on everybody to report. Even bad attitude should be reported, because then that's the only way people can change. That's the only way we can ensure that the patients are getting what they ask for. The people go to hospital not because they love going to the hospital, it's because they have to. And so when they come to us, and the people that work there chose to work there, and then we as a government pay them to provide those services. So we expect the best standard of care and good customer service.
So if that is for the hospital, but if a practitioner falls short of professionalism,
it's the same thing.
The right to you as well.
It is the same. Yes. Some people even go away and go and write to MDCN directly. Some people do that. But if they write to us that this doctor did this, that, we're going to investigate. We're going to find out. And then we're going to reply to the person and say, yes, thank you for letting us know. We found out that. And if that happens, it's because maybe the doctor was negligent, or maybe he hasn't even renewed his license. We shut you down even if you haven't renewed your license. And until you renew your license, because MDCN is the one that renews licenses based on certain things. It's not our job to renew your license. It's your responsibility as a practitioner to renew. And if you do not renew your license, you're shut down. It's actually a straightforward, there's no qualms about it. A farmer does their job, they go, they look, they write what the offense is, they write to the person, and they shut you down straight away.
Now, so with that now, you said the right to you. This is more of educating the people as well. So can you tell us specifics? Who do they write to? Is it an email? Is it a physical letter? So that our listeners and viewers on YouTube can also hear this.
My advice is, if it's a primary healthcare setting, it happened, please write to the primary healthcare board. And you can ask anybody right there. It's always also nice to report it to the MOH, the head.
Okay.
It's nice so that they can nip it right there. It's not everything that needs to come to Ministry of Health. I say that because and this happens globally, you're not satisfied with the way a nurse talks to you, right there and there, whatever, we don't know what's going on, you go and report to their superior, to their direct, please, can I see the person in charge of this place? So that person gets it firsthand. And we train all our workers that nip it.
Right there.
Nip it. Maybe you only take sorry. I apologize. Or somebody says, I've been waiting forever. They ignored me. Maybe they missed whatever. They can settle it right there and there. However, if it's something bigger than that, where maybe, like you said, this is crazy. I could have lost this. I could have lost an eye, whatever. You can report immediately right there and there. But please write to the primary healthcare board. They will take it up because they know the process before it gets to us, or before that person reports to the lawyer. Sometimes people don't report to anybody, they just go straight to the lawyer, and the lawyer gets in touch with the commissioner or her farmer. It's either one, because the lawyer knows who to go and get. Same thing with the secondary healthcare setting. There's Health Service Commission, but it's usually best to go to the MD of that hospital, because they have a health management board that they will sit down and discuss it. Issues that are not solved at that level comes to us. If it comes to us directly, we refer it to the agency that is responsible, give us feedback. So I'm not the one that's going to go to the hospital and investigate the doctor or whatever. There is a process, and it's a process that works. From Health Service Commission, comes to us, this is what our findings are, and all that. If we do not agree with the findings, we'll conduct our own investigation. And that's what we do. And we take it seriously. We really do. It's painful when we get reports. Either somebody has died and they believe that it was, and they're not all the hospital's fault. Some people are just, if you bring somebody in dead, and then you're now blaming maybe the general hospital that they didn't do enough. as long as they've documented and the reason why and what they did, at the end of the day, it's not really the hospital's fault. And then when you really investigate, and some people will accept it. Because don't forget that when people are grieving, they look for somebody to blame. And it's so easy for people to blame the hospital, the nurse, the doctor, or government. So we do take it seriously.
Okay, and finally here, as an average Lagosian, should I be concerned about the health service or provision in Lagos, seeing that we have, well, we'll say there are certain diseases people just have to travel out of Nigeria or travel, go to all those places. Should an average Nigerian be concerned that he or she cannot get quality health care in Lagos?
So you're talking private and public together?
Private and public together, the entire structure.
So there's something, the medical tourism that you're talking about is a totally different issue. I always say, yes, the government may be responsible to provide you with that care, but you also have to take responsibility. For every single individual must be responsible for their own health. However, if you seek help on time, if you seek help appropriately, there's no reason why you need to travel out. There's no reason why. Now, the only reason I would say somebody will travel out is if it's a delicate, they've already seen the doctor here. They've already done everything that needs to be done. However, what that person needs, we do not have the capacity to do it because we do not have the trained personnel to do it. It's an advanced thing. And we also know that there's actually a treatment that you can have, but we actually do not have it here. That one, absolutely, you will go abroad, they go to India, they go to the, however, general things. So let me just say the most basic things. We encourage people to know their numbers. You as an individual, what's your high blood pressure? What's the average? What's your blood sugar level? How do you feel? Do you do regular checks once a year? It's better to prevent diseases or an illness than you get that illness. People are dropping dead, young people, 30-something-year-old, and their blood pressure, when you check it, even before maybe they faint or whatever, you check it, how can a 30-something-year-old have 200 over 140? That's not the government's fault. But say it may be life, the environment, the traffic, or whatever, but you're not looking after yourself enough to know that you need to see a doctor. You don't need to go abroad to check your blood pressure. You don't need to go abroad to check what you eat, your blood sugar. You don't need to go abroad to know your numbers. You should know your numbers. You should know that, oh, this is high for me. Oh, I have a headache. This headache is constant. It doesn't mean there's something bad, but you have an idea of what it is. So absolutely you can stay in Nigeria. If I don't feel unwell, why would I go abroad? I will first of all actually go to a hospital here or see a doctor here. And we have a lot of specialist doctors. We have cancer centers, private. You do not need to go and have chemotherapy or whatever outside the country. We have. But some people, it doesn't matter what you say, they're comfortable that, no, I'm going to go and get the best care. And yet we have Nigerians dying abroad. We have errors being made. I worked in America. I know where they're making errors. And that's why litigation is so high there, because they have standards. And so when people complain, and their insurance is so high, every single member of medical staff is insured in case somebody sues you. Because people make errors. We're human. And also in Nigeria, go for a second opinion. You must go, if they tell you something and you're not sure, just like you went for your eyes, somebody said something and then you went to see another doctor. That's what we call a second opinion. Just see what it is. This diagnosis happens everywhere, globally. America, England, they sue them. Nigerians, when I was working in America in cancer care, I mean, Nigerians go, oh, are you Nigerian? Yes, I am. I mean, my name says it all, or whatever. They meet Nigerians. There was something not too long ago in England. It was Nigerians, the Nigerian doctor on call, the nurse was on call, the administrator was on call. They're all Nigerians. And guess what? They were trained here. We gave them that training. But they went there to obviously expand on that training. You can get anything you want in Nigeria. And then with the diaspora doctors coming in, things can be arranged for you. You don't have to leave the country. come back. So we have a lot of people who were, I went for the care there. How can they charge me £400 for dressing change? And what do they use for the dressing? We have it here for a wound. It's because people have money to go abroad. But that trust, hopefully in Lagos, is coming back when people use the private sector or the public sector, and then they go and say, "Oh my gosh, I couldn't believe it. This is a Nigerian hospital." We get those a lot. It's just that the media don't hear about it. Some people will write it in WhatsApp and then you see forwarded many times. Our commissioner, for example, had something wrong with his eye. He went to Lasuth. They did it there. So it's not, if God forbid our governor feels ill or whatever, there'll be doctors to come and see him. He's not going to rush out of the country whatever. So if we in the health sector are saying we use the same system, that should be enough trust for people. Nobody wants to kind of like die early.
Maybe it's time you publicize it a lot more. When you go to the hospital, let us know.
And you know what? And one of the issues, one of the problems now, this is what I would call a problem or a challenge, is that as a government, we do not really make a lot of noise about what we do. I have friends who will be sitting down and say, Kemi, no, government, I just say, do you know we have this, that? I didn't know. I didn't know. If I knew, I won't be saying what I said. And it's true. And that's where we don't, and we're beginning to do that, to showcase what it is we're doing, to showcase what is available, to showcase that, look, they're intelligent, smart people, and the governor is a caring person, compassionate, wants everybody just to do well. The economic situation, we understand it. So we're giving you things free. So make use of it. But it is also the individual's responsibility. We can only do so much.
All right. Dr. Kemi Ogunyemi, SA to the Governor of Lagos State on Health. We thank you for your time with us today.
Thank you very much.
Great.
Have a good day.
And that's how we wrap up the show. We say thank you for being a part of it. Another edition of Lagos Weekly done for today. We've brought you insights on the health sector in Nigeria, what the limitations are, the challenges are, the opportunities that are there, what your responsibilities are, and what the responsibilities of the government are. My name is Oluwakayode, on socials at IamIPOSU. Let's keep talking, let's keep interacting, let's keep exchanging ideas. Let's keep holding government to account, and let's keep our ears out there so that we can know what government is doing as well, take advantage of it. See you next week. Bye-bye.